Thank you. Thank you very much. Thank you for inviting me for this talk on rare pulmonary pathology. Initial uh, program that went out was about non-neoplastic pulmonary pathology, but then I realized that some of the slides that I have included in my talk today are actually neoplastic. So my apologies for it. I, I, I know in the previous meeting I've sent two papers for reading, but probably these may not have been sent to you guys. So I would say there is an updated Royal College of Pathologists document on tissue pathways on non-neoplastic pulmonary pathology, published late 2024. It's worth reading that. And also, there is a diagnosis of cystic lung diseases, a position statement from UK Cystic Lung Disease Rare Disease Collaborative Network, published in Thorax. It's worth reading because the conditions of the entities that we are going to discuss today are very well covered in that. So the first case was a biopsy from a lady who had repeated pneumothorax, and those of you who would have seen the slides, are, I'm not saying that these slides are from the same case, but if you see these, there are multiple cysts present in a haphazard fashion in the lung tissue that has been submitted, and the areas that have been marked with arrows are the areas of interest in this particular entity. And if you zoom into those areas, you will see these anastomosing vascular channels which are surrounded by bland looking spindle cells. These are not very mature cells, and if you, some of the immunostains that I have sent you guys would give you an idea of what we're dealing with it, and it's positive for the estrogen and progesterone receptor. It's also standing for smooth muscle actin and HMB45. So I'm sure you would have worked out by now that we're dealing with lymphangiomyomatosis. And we in Nottingham, along with the help of Brompton Hospital in London, have a bi-monthly, well, every 2 months we have a rare cystic lung MDT, in which cystic diseases in the lung are presented from all over UK, where we discuss the causes of these cysts in the lung, and individual patients' CT histology is available, and we work out what is the cause for those cysts. And we published this article after going through 100 patients, and we realized there are 4 main entities that we are dealing with on a routine basis. And those 4 entities include lymphangiomyomatosis, as the first case in this case is. Second is pulmonary Langerhans cell histiocytosis. Third one is Birt-Hogg-Dubé syndrome. Fourth is lymphoid interstitial pneumonia. So these are the 4 big entities that we come across in our routine specialized practice within that national MDT. Of course, lymphangiomyomatosis exclusively affects females, women, rarely males, very rarely, I would say 99.99%, it's the females which are affected by this condition. It's up to 60% of the women with tuberous sclerosis complex, TSC, have lymphangiomyomatosis. They present with dyspnea and pneumothorax, and that's along with the cysts, and these are cysts which rupture as a result of weak wall that causes the pneumothorax. The other pathologies that we see in these unfortunate female patients is presence of lymphadenopathy, chylous pleural and abdominal effusions. CT, along with CT chest, we also always do CT of the abdomen to look for renal angiomyolipomas and any cystic masses that further confirms. The radiological appearances are quite classic. So radiologists in our group, both from Nottingham and from Brompton, are quite used to seeing these cysts, and they usually can comment whether they agree with the diagnosis of Lamb or not. In entities where they are not sure, only then we go for biopsy. Lamb cells are specific cells which stain with HMB45, S100, smooth muscle actin, estrogen, and progesterone receptor. The Lamb cells have TSC1 or TSC2 mutations. Of course, HMB is shared with other members of the family of tumors like angiomyolipoma and clear cell tumor of the lung, basically. It's a multi-system disease occurring in sporadic form. As we already alluded, the most early recognized presentation on dyspnea or pneumothorax. There are treatments now available for this entity, so it is very important to diagnose them and refer to an appropriate center. Here, Professor Simon Johnson is the national expert for lymphangiomyomatosis, and they do prescribe mTOR inhibitor therapy in patients with lymphangiomyomatosis. Clinical course of LAM varies from asymptomatic disease to progressive loss of function. Of course, symptoms worsen during menses and during pregnancy, and majority of the patients develop pneumothorax or lose their lung function. That's why these patients have regular lung function tests. Patients are usually advised to refrain from estrogen-based contraceptive pills and hormone replacement therapy. The mTOR inhibitor, which are given to patients, the main drug is sirolimus, and it does reduce the lung function. The mTOR inhibitors are effective for lymphatic disease, for angiomyolipoma, and other features of TSC. So there you go. That's lymphangiomyomatosis. We did an audit of pneumothorax in our department over the last 5 years, and we had 3 cases in our over 100 cases of lymphangiomyomatosis. We also had 3 cases of Burt-Hogg-Dubé syndrome. And although I have not put any slide for Burt BHD, but I will briefly touch on it. What is this entity? But the second case in the slides that I have presented to you is this, where you've got lung cysts. Lung is infiltrated, is a multifocal infiltrate by histiocytes, as you can see here. The histiocytes with ample cytoplasm and the nuclei, coffee bean nuclei, present, surrounded by dense infiltrate of eosinophils. As you can see here, histiocytes. These histiocytes, if you look at the slides, or these cells are staining for S100 and CD1A, which usually clinches the diagnosis of Langerhans cell histiocytosis. Langerhans cell histiocytosis is a smoking-related condition in adults. Of course, it occurs in children as well. Uh, in children, it's a multisystemic disease. It doesn't only affect lungs, it also affects the bones, the skin. Uh, Common presentation is with cough and dyspnea, occasionally fatigue, weight loss, and sweats. A smaller proportion of patients will present with pneumothorax. Of course, CT is very diagnostic of this entity, where it shows reticulonodular changes. Uh, you can also see the evolutionary process within the nodules where they cavitate to form irregular cysts. The disease is more marked in the upper and middle zones of the lung. Uh, in the active disease, the nodules and thick walled cysts will predominate. Uh, of course, because the patients are usually cigarette smokers, they will also have coexisting smoking related entities like desquamative interstitial pneumonia, respiratory bronchiolitis, ILD, emphysema. So, all those extra entities will also be present. And in fact, one of the treatment of Langerhans cell histiocytosis in adults is to refrain from cigarette smoking. We're seeing increasing number of younger patients who are smoking or coming to light with this entity. What else? In children, the disease is systemic. It involves the bone, the skin, and the pituitary gland. There are activating mutations in the oncogene MAPK-ERK signaling pathway in 80% of the patients. And they also have BRAF mutations. And BRAF mutations are actually druggable. So treatment is available for Langerhans cell histiocytosis. The survival is more than 90% for 10 years. The prevalence of malignancy is high, 17-fold, and that's usually due to associated cigarette smoking. So there you go, Langerhans cell histiocytosis. I want to briefly touch on BHD, Birt-Hogg-Dubé syndrome. These were Canadian physicians who actually, first three of them, who described this entity. And there's a combination of skin hematomas, lung cysts, and the risk of renal cancer in Birt-Hogg-Dubé syndrome. Histopathology point of view, we don't see much apart from having lung cysts randomly distributed in the lung without any lining. So they are different from the cysts that we get in lymphangial myomatosis, where they would be lined by immature lymphoid cells. Here, there is no lining. You just have presence of lung cysts. But then you have got other entities. So if you see the patient will have facial fibrofolliculomas, or as we call them, hematomas. So lung cyst, presence of facial fibrofolliculomas, as you can see here. Lung cysts without any lining, although they look like emphysematous cystic spaces, but this is taken from a patient with BHD. It's caused by loss of follicular function. Lung cyst, facial fibrofolliculomas, family history of pneumothorax, or early onset renal tumors should raise the suspicion of PhD. As I said, morphology of cyst is not diagnostic. There is no progressive loss of respiratory function. So from the point of view of prognosis, this entity is better than the lymphangiomyomatosis or Langerhans cell histiocytosis. The only thing is, if in the kidney there is renal cell carcinoma, then the prognosis is determined by the renal cell carcinoma. Otherwise, from presence of lung cysts, it's non-progressive, so it doesn't lead to loss of any respiratory function. The only treatment, if any, required for the lung cyst is if they rupture and cause pneumothorax, then that would require treatment. Okay. I'm not exactly sure how is the slides that you have been given numbered, but I think the next case is a case of organizing pneumonia. And you would have seen the slide with presence of organizing pneumonia. You would have seen fibroblastic plugs called meson bodies filling the air space. So these are bodies that travel from one alveolus into the second alveolus through the pore of Kohn. The condition is associated with usually infections, inhalants, drugs, collagen vascular disorders, or it can be idiopathic. The process can be single or it could be multifocal. So if there are multifocal nodules, the suspicion will be metastasis. So this is why usually either a biopsy or a wedge excision of the lesion is carried out. Presenting features include cough, fever, dyspnea, and malaise. As I said, because the process is very patchy, the malignancy is in the differential diagnosis, and it does respond to steroid therapy. So, organizing pneumonia. The next slide will be, if you, I'm sorry, I'm unable to project these slides because they are in a different presentation. I have not been able to open those. But if you look at the slide, it's alveolar spaces which are filled with hemosiderin-laden macrophages. And I have included the Byers stain, which is the iron stain in those slides to differentiate it from the other types of pigments that we get with cigarette smoking, like anthracosis. So it's important to distinguish between two. This is not anthracosis. This is hemosidrosis. And it can be secondary, it can be primary, or it can be secondary. The causes include pulmonary, cardiovascular, and immune system disorders. It's usually seen either due to bleeding disorders or mitral stenosis, but it can be without any known etiology. Autoimmune vascular disorders, Goodpasture syndrome, drug-induced, it can be drug-induced. It could be due to lymphangiomyomatosis or may be seen in veno-occlusive disease. So pulmonary hemosidrosis 1, 2, and 3. 1 due to anti-basement membrane antibody. PH2 due to immune complex diseases like SLE. And PH3, no immune system involvement. it's been established that there are some structural defects in the basement membrane of alveolar capillaries and endothelial cells, which is responsible for the leakage of blood into the alveolar spaces. And over the time, macrophages come in and break down the, the, the heme component, and iron gets into the alveolar spaces, but it can also get deposited in into the alveolar walls. Neutrophils are also known to play some role in the etiology. The presentation is due to the shortness of breaths, coughing, hemopsis due to recurrent bleeding into lungs. The condition does respond to immunosuppressive therapy, and that establishes the immune nature of the process. Okay. Give me a minute, please. So the next two sets of slides will be familiar with non-gazetting epithelioid granulomas that are present. One slide is a lymph node that contains a lot of non-gazetting granulomas, almost confluent. So in Nottingham, we have several lung-related MDTs. So lung cancer, we have two MDTs, one on Monday and one on Wednesday. Then we got interstitial lung disease MDT, ILD MDT, which is held once a month, where pathologists along with radiologists and clinicians are sitting and work out what's the underlying cause for interstitial lung disease. And then the fourth one is the rare cystic lung disease MDT. So these are four different types of MDTs we hold in Nottingham. And this is ILD MDT, where we discuss what's the reason for the interstitial lung disease. Is it UIP? Is it LIP? Is it granulomatous diseases? Is it extrinsic allergic conjunctivitis? And radiologists and pathologists coming together with the clinicians who have experience in dealing with ILD usually come up with diagnosis in majority of the cases. For a pathologist, we are quite used to seeing granulomas. It's a very easy diagnosis to make. The granulomas. In that second slide that's been sent to you guys is the lung itself, which is containing non-gazetting granulomas, and they are haphazardly arranged. They are non-gazetting granulomas. Whenever we see non-gazetting granulomas, then the differential diagnosis usually includes sarcoidosis and extrinsic allergic alveolitis. The entity that you are dealing with is sarcoidosis, basically. But of course, TB, fungal infections, vaginous granulomatosis, bronchocentric granulomatosis due to fungal infection, eosinophilic granulomatosis with polyangiitis, aspiration, drug abuse, hypersensitivity pneumonia, all will be in the differential diagnosis. So if you have made a diagnosis of granulomatous disease, then you have narrowed it down to certain entities that it could be. Of course, we are seeing an increasing incidence of tuberculosis in UK, and that's not only HIV, but autoimmune suppression due to organ transplantation, that is also giving us a lot of granulomatous disorders. TB, we're seeing multi-drug resistant organisms on the rise. So we always recommend to our surgeons, especially who are doing frozen sections, first to avoid doing any frozen sections if you're suspecting TB or granulomatous process, because it does shut our equipments for 24 hours to get rid of the infection. But whenever they send us a piece of tissue for frozen section to rule out malignancy, and we suspect by looking at it that it may be TB, then we will submit a portion of that tissue for culture. And also we'll do a touch prep, and we will avoid doing a frozen section because it exposes the laboratory staff to infection. Of course, after ZN staining, to look for organisms in the central zone of necrosis. Some centers recommend PCR helping in detection, although PCR, mycobacterial tuberculosis PCR, has been shown to be positive in tap water sometimes. We will not be able to distinguish histologically between atypical mycobacteriosis and typical mycobacteriosis. Atypical is caused by group of organisms like Mycobacterium kenzai, Mycobacterium xenopi, and Mycobacterium abscessus. Atypical organisms stain with ZN. They're longer, thicker, and coarsely beaded. But as I said, we can't on our study determine that. It needs culture and PCR for precise speciation. There is one slide where you would see this in the bronchus. There are colonies of fungal organisms. So granulomatous inflammation with fungal organisms. As I said, if infection is suspected, always send it for culture, because although in this case the fungal colony is aspergillus, it's always better to send it for culture, because microbiologists are better in giving a proper name to these organisms. There are so many new entities being described on a yearly basis that we are, as histopathologists, unable to keep pace with that development. It's generally related to patients in asthma, the allergic bronchopulmonary aspergillosis. So, yeah. There is one other slide where I've put, there's some extra cellular deposition of fibrillary protein in the lung. And it's a thing in the form of nodular distribution, but it can be nodular, diffuse parenchymal, alveolar septal, and diffuse interstitial. And those are examples of amyloid deposition. Amyloid deposition can be primary or secondary. Primary is more common and confined to lung. Up to 30% of primary amyloid is due to multiple myeloma or B-cell lymphoma. 10 to 15% of patients with multiple myeloma will develop pulmonary amyloidosis. Amyloidosis can be associated with Sjogren syndrome. The presentation can be very atypical, like with pleural effusion, sometimes mediastinal lymphadenopathy. If the nodular deposits are quite large, hamper the pulmonary circulation, and can lead to pulmonary hypertension. Of course, it goes without saying that localized amyloidosis is better than the generalized amyloidosis. I think presence of amyloid in the lung does not lead to much prognostic failures. It's usually related to the involvement of the heart. And in the heart, if the deposits are anywhere near the conducting system, such as SA node, then the chances of arrhythmias and ventricular disorders will affect the prognosis. So cardiac involvement is more important. In the lung, if we see amyloid in the lung, then There is an amyloid center in London. That's where all the tissue blocks, the paraffin embedded tissue blocks, are sent for further classification. Of course, if it's AL, then monoclonal light chain will be produced in the bone marrow, which occurs in multiple myeloma, Waldenstrom's, macroglobulinemia, lymphoma with kappa, and lambda light chain restriction. So light chain associated is AL, and the second type is AA, secondary amyloidosis, which is usually seen in chronic conditions like rheumatoid arthritis, chronic osteomyelitis, granulomatous inflammation, especially TB. It used to be very common in patients with TB having amyloidosis. Hereditary amyloidosis is also known to occur, and there are mutations in transthyretin gene. Dialysis, the chronic renal patients who have chronic renal failure, when they are on dialysis for a very long time, then they are prone to develop beta microglobin amyloidosis. So always suspect that in patients who have cardiac failure or respiratory failure. And then there is wild type amyloidosis. Now, for amyloidosis, we in histopathology laboratories will do Congo red staining or serous red staining. But there are entities, there are some times when we notice that the slide is not staining, it's not giving you the orange tinge or the pinkish red tinge that we see with Congo red. And that is because you are not dealing with amyloid. What you're dealing with is light chain deposits. And light chain deposits morphologically will look similar to amyloid, but they are negative for Congo rich. They're Congo rich negative. They will not stain with serous red or Congo red stain, and will not show any apple green birefringence. That usually is a sign of light chain deposition. And if you do immune electrophoresis, then you would find those light chains in the serum of these patients. So do not always assume that pinkish material deposition in the lungs or the kidney or the liver is always due to amyloidosis. It can be due to light chain deposits. Of course, in some cases, amyloid and light chain deposition may be seen in the same patient. I think I've covered most of the slides that have been sent. If I've missed out on any, please let me know, because unfortunately I'm not able to see those slides that you have been given. Although I have submitted those slides, but I don't remember the order in which I submitted them. If you have any questions, please feel free to ask. No? Okay.
I don't think there's any questions at the moment. I will work with Richard to make sure everyone gets the slides that you discussed today, and they can compare to the presentation and the slides available.
Thank you. Thank you very much.
So if there is no questions, we can finish up early today, guys. Does anyone have anything to say?
Okay. Thank you.
No worries. Thank you very much, everyone.
Thank you.